Okay, good morning. Welcome to everybody. It's very early, so I think we were fine to start 5 minutes later. My name is Derik Hermann. I would like to welcome you to this session on current data on monthly buprenorphine in opioid use disorder treatment by individual. And we have 3 speakers today. I will start with an introduction on the product, on buprenorphine extended release formulation of which I will describe from what is this product, what are clinical studies on this, and why is the dosage in the way it is. And then we will have 2 other speakers who will give us some clinical impressions from treating patients with extended release buprenorphine, and I will pass over to them after the clinical data. Okay, my name is Derik Hermann. I'm a specialist in psychiatry and psychotherapy. I'm working in a known psychiatric office now for 3 months, and in Germany in Landau, also in opioid maintenance treatment. I'm an associate professor of the University of Heidelberg in Germany and worked 20 years in an addiction department of the Central Institute of Mental Health in Mannheim. And after that, 5 years as a physician in a drug rehabilitation clinic and drug counseling. Scientifically, I have about 90 publications also on opioid dependence. My disclosures are, I get a honoraria for this talk from Indivior, other you can see there. And then we start right into the topic. The monthly buprenorphine depot formulation consists of a biocompatible solvent, a biodegradable polymer, and both are linked to buprenorphine. So in a little bit more detail, if you inject this buprenorphine depot subcutaneous, then in the first step, water diffuses into this solution, and the buprenorphine gets out very fast. And the challenge is that when you give this injection, you would like to have a sufficient concentration of buprenorphine in the body, in the brain, very fast. You want it on the first day already to be in a therapeutic value. That's why it just goes up very fast when water comes in and buprenorphine diffuses out. In the second phase, you have here a beginning degradation of a polymer, which is seen here as a green color in the surrounding, and then this process of liberation of buprenorphine just slows down, which you can see here. And when this process of polymerization is finished, then you have a very slow release over 4 weeks of this buprenorphine, and that's how it works. The advantage of a depot formulation is that normally if you have a daily intake, you can see that there are every day we have a sharp rise and then a little bit slower decrease of the concentration of buprenorphine, and this is just leading to this way that it just comes up and down, up and down, up and down, and with a depot formulation you have a very constant level of buprenorphine in your blood. So what are the advantages? The first one is that you have constant serum levels for 1 month. The second is that if you inject this depot formulation, then the person cannot give it away to other people and divide it. It's not possible to use buprenorphine then nasal or intravenously. It cannot be lost. which sometimes is a problem if you give patients take home and they lose it and they come and want to get just a new one, which is a problem sometimes. The tablets cannot be forgotten, which is also makes life easier. You have less contact with the drug scene, a very important point, because if you get a monthly injection, you only need to come to the doctor or to the place where it's given, where the other drug addicts are, once a month. And you have more time to work, for childcare, for traveling. And you are less recognizable as a drug addict. And therefore, you have less discrimination, less stigmatization, and it's a normalization of your life. Of course, there are not only advantages, but there can also be problems. First of all, the daily dosing is a kind of ritual which ensures the person that afterwards you have buprenorphine in your body, you can taste it, you can feel it, and that makes you sure that there don't need to be any withdrawal signs. And from this psychological point where the intake is by learning mechanism conditioned to the feeling of security, this just falls away, and this can be a kind of problem in some people. You have fewer appointments with a substitution physician, therefore urine drug tests are predictable, and if this is a problem, there are solutions, especially when you have the opportunity to do online monitored drug urine tests at home with marker urine, which we are doing in my psychiatric office with patients on substitution therapy, and which is working quite well. Of course, the less contact to the substitution team can be a problem if the person is unstable and maybe takes also other drugs or alcohol. When the person comes to every day take in, then you can see is the one intoxicated, and this you can't do when the one just comes once a month. And of course, when you have other physical conditions like constipation, then you have the problem that the buprenorphine is in the body and you can't remove it, so you have to choose other ways to treat patients if these problems appear. So now we come to the dosing rationale, and from buprenorphine we know that it works in the brain and binds to mu-opioid receptors. And then we know that depending on dose, buprenorphine has just different ways of action. For an analgesic effect, you don't need much buprenorphine, just an occupation of about 1/3 of the mu-opioid receptors is enough for beginning analgesic effects. For the suppression of withdrawal, you need about 50 to 60% mu-opioid receptor occupancy, and for the blockade of effects of other opioids, if you have buprenorphine in your body and take another, e.g. heroin or fentanyl, then you need about a blockade of 70 to 80% of receptors by buprenorphine to block the opioid effects. And now the good question is, how do we know that this is the case? And what is the research behind that? And therefore I will shortly go into details of the studies that were performed to show these dosing regime. The studies were performed using PET, positron emission tomography, which in shortly is done by using carfentanil as an opioid agonist, which is connected with a radioactive isotope with a very short half-time, 11C, and then if this combination is injected, then you can see effects that that this carfentanil binds to opioid receptor in the brain, and this is what you see in the first line when placebo is given, and then this carfentanil 11C is injected. You can see the opioid receptors. The highest concentration is a red point, and then the color yellow is where the second most receptors are. And so you can see the distribution of the opioid receptors in the brain in the first row. If you then give the patient buprenorphine in different doses, if you give 2 milligrams, you see that there are less green and red colors in the second row, and this is because of the carfentanil is displaced from the receptor by buprenorphine, and therefore you have a less green color. If you give a higher dose, almost all receptors are blocked by activated by buprenorphine, and therefore also almost no 11C and carfentanil is binded. With this technique, you can in a living person just quantify the opioid receptors. And for the determination of at which concentration of or at how many opioid receptors must be occupied at the point when withdrawal symptoms appear, you simply give with the same experiment procedures. Again, you give buprenorphine and then you just wait, and you can see that when buprenorphine is metabolized and goes down in the concentration, then you can see again that, that the opioid receptors appear, and after 76 hours, buprenorphine is almost completely gone, and then you can determine the time after buprenorphine in the brain receptors, and about opioid withdrawal signs appeared at about a concentration of about 50 to 40% occupation of the opioid receptors. So this was the first experiment showing that withdrawal signs appear at 40 to 50% receptor occupation. And then we have another experiment where, in this case, you can see here that this is a visual analog scale of the high effects of opioids. And in this experiment, you give at a screening point where patients have no other opioids in their system. You give a challenge of hydromorphine, which produces then high effects, which is higher at the dose of 18 milligrams in comparison to 6 milligrams. And afterwards, you repeat the session when you have given, in this first 2 weeks, buprenorphine naloxone film for 14 days, which completely suppresses, almost completely suppresses the high feeling after a hydromorphone challenge. Then this monthly buprenorphine was injected on 2 time points, and you can see that over the whole period of 3 months, the effect of hydromorphine was about 0, meaning that if someone takes another opioid when on buprenorphine depot, there's no feeling of high, as in, therefore, people will make the experience that opioids are no longer rewarding, and then there's no need to additionally use other opioids in combination with this buprenorphine substitution. So again, we have this explanation for this about 50% opioid receptor occupancy for withdrawal suppression and about 70 to 80% for blockade of the effects of other opioids. And then we come to the question, what is the right dose? here on the left, you can see mu opioid receptor occupancy on this axis and buprenorphine concentration in nanogram per milliliter measured in the plasma. And you can see this relationship, which is here about Cetiphate at about 90% receptor occupation, probably the reason why buprenorphine, why the ventilation suppression by opioids is not complete with buprenorphine alone, because it's not 100%, but only 91% receptor occupation. Here you can see that 70% opioid receptor occupation resides in a plasma concentration from 2 nanogram per milliliter. So you need this, about this concentration to suppress the positive effects, the rewarding effects of other opioids. So this concentration with a special range, when you see the range at 1 milligram buprenorphine, you only have about a receptor occupation from 50 to 60%. So at 1 nanogram per milliliter, probably you can suppress withdrawal symptoms, and you need about 2 milligrams for a suppression of effects of other opioids. This is also very similar to observations in clinical observations that in urine testing, less persons had another opioid when reaching this concentration of 2 to 2.5 nanograms buprenorphine. Based on these data, the dosing regime was built, and here you can see that we have the dosing regime of monthly buprenorphine depot with 2 injections of 300 milligrams for the initiation of the effect, and then going on with 100 milligram injections, resulting in constant levels. The aim was to be a little bit at all time points, it should be above of 2 nanograms per milliliter, at least above 1 nanogram per milliliter. And by this, you can see that in the first month, with the first injection, it first goes up a little bit, and then you come in this constant level, which is about, in the average, about 2 nanogram per milliliter. But you can see, as this is a standard deviation, that a certain amount of patients still are below these 2 nanograms, which is completely changed after the second injection. Then really all of these values are above 2 nanograms per milliliter. And that's why this buprenorphine depot injection is on a scientific basis a very effective medication, and I think it's very interesting just to compare this concentration and the results of the research that you need 2 nanograms to be effective. When you compare this with just sublingual buprenorphine, you can see here 8 milligrams sublingual formulations, and then the 100 and 300 milligrams of depot injections. The average at 8 milligram is 1.4, at 12 milligram 1.8, at 16 milligrams you come in the average above this 2 nanograms of 2.2 about. However, you see the range, and you can clearly see that the injection of 300 milligrams resides in the highest values of plasma concentration. And just for getting a feeling what the dosage is, you clearly can see that the depot injections result in higher dosages than the usual sublingual tablets. Clinical studies. I will first show you some data of the phase 3 registration study, which was a randomized controlled trial trial in the US with about 500 patients. This was a study performed against or versus placebo. And in short, this was successful with less opioid use, more days of abstinence, and fewer withdrawal symptoms, lower cravings. This study was then enlarged by a follow-up study on safety, patient satisfaction, and tolerability. And there are other studies also, which are not randomized controlled trials, but have another design which is more on the clinical daily life. And these studies showed increased employment, more working hours, a higher quality of life, improved social situations and lifestyle. There's another study in Australia done which shows a high retention rate and also improved quality of life, employment, and treatment satisfaction. There will not be the time to go in details for the last two studies, but I will give some details of the first two studies. So the approval studies in the US was done as a multi-center study in 36 treatment centers in the US. It was a 6-month treatment using 3 arms. One arm was that you give 6 months 300 milligrams Subutex. The other was 2 times 300 milligrams and 4 times 100 milligrams, which is a standard dose, and this was compared to placebo. The primary efficacy endpoint was abstinence percentage from opioid use. And results are here displayed as a heat map, where you can see in green color those those who were abstinent, who had a negative urine drug test, and also when asked that they consumed no opioids. And in red are those with a positive urine. And on the first glance, you can see 2 things. First of all, in placebo, there are much more red points than in both of the treatment arms. And the other point is that this figure looks that here there are a lot of missing data which are less at both treatment arms. And to put this a little bit more in numbers, you can here you see the primary efficacy endpoints with placebo, where you can see that the abstinence rate was about, in the beginning, about 20% and then coming down very fast to 10% and below. And for resulting in a complete abstinence rate of 5% in comparison to both treatment arms, which result in abstinence rates of about 40%. And this is the main result, a significant result, and of course what might have been expected, because from studies before we already knew that buprenorphine is effective. And so this depot also is showing, is just confirming this result. Then you can see that we have also lower opioid withdrawal signs in the depot groups in comparison to placebo. In blue again, placebo, which has a higher rating in withdrawal, and the 2 treatment arms, which constantly show low withdrawal. Similar picture for opioid craving, which also is higher in placebo and lower in the treatment groups. What you already could have seen from the missing data in the heat map, it's repeated here, that the time from randomization to study discontinuation is quite higher in those treated. So you can see that right at the beginning, a lot of patients on placebo just quitted the study, and you see a retention rate of about 80%, 70 to 80% in those on buprenorphine depot. That was the results of the first study for approval, and this study was enlarged, giving the opportunity to other patients to come into this study. And here we can see, if we only look at the blue and the gray line, you can see that these are the results of the first study. At this time point, when the study was ended after 6 months, patients on placebo got the opportunity to also get the study medication, and then they rose in abstinence rate very fast. Another study group was also included, starting in this red line, which is done not only over 6 months, but over 12 months, and constantly shows that it still goes up after 6 months a little bit in the abstinence rate of about 5 to 10%. So this study was done to do some safety assessments, and we can see that the discontinuation of treatment due to adverse events was less than 4% of the patients. That a dose reduction from 300 milligram Subutex depot to 100 milligram Subutex depot due to adverse events was only observed in about 7% of the patients, and that adverse injection site events occurred in 16% of the new patients and 8% of the rollover patients. Patients with 12 months on active treatment reported fewer adverse events than at baseline, showing that it goes better when people take it longer and get used to. Adverse events from the study. If we see these adverse events, then we see that here we have the study groups, 4 study groups. The new patients showed at the beginning more constipation than those already 6 months on buprenorphine depot, which I think is just normal. In the beginning of an opioid, you have more constipation in comparison to when you're used to it. The second point I would like to show is that, of course, you have injection site erythema and pain, and these effects are higher in the patients at the first injections. It seems that also here the body gets used to this medication and then shows a smaller reaction. Patients were also asked how satisfied they were with the medication, and about 85 to 89% were satisfied, very satisfied, or even better. So I already come to a summary. I showed you that in this clinical phase 3 studies, Subutex depot was better than placebo concerning less opioid use, more days of abstinence, fewer withdrawal signs, lower cravings, and the open follow-up study on safety showed a high patient satisfaction and tolerability. Other studies showed that these effects also transfer positive effects to social situations and quality of life, improvement of the working situation, which is also confirmed in a study in Australia. So you see that also in different settings, this buprenorphine depot has positive effects. I thank you very much for the attention. These are some further information, which you can also see in the internet. Thank you for your attention. I think we will have some time for questions. Maybe we can make it the way that if you have direct questions on understanding, we can answer like 2 or 3 questions now, and after all 3 speakers have done, we have a little bit more time even for questions. Are there any questions?
Markus Partanen from Finland, addiction doctor. I was wondering about those Greenwald studies, those concentration against how much is suppressed those mu receptors. In Finland, I think this 2 nanogram per milliliter is really well penetrated to doctors, but it seems that doctors are quite strictly going with that. But as you showed, that there was quite much difference between patients, so that even some patients with 3 nanograms, it was about 70 to 80% of occupancy. So it should be managed like patient-based when they have symptoms. This should be addressed so that maybe they need a bit more dose in that way. But in Finland, many of course change it that way, but some doctors are quite strictly with that 2 nanograms.
Well, I didn't get the question.
Yeah, what do you think about this, about going up or down with patient preference or patient-based in that way?
So the question is, of course it is in the individual, it's quite variable, and as a clinician, you also have to look what are the effects, which are not always the same in patients, and you have a variability which you just have to look at. And of course, these values were average values. These positron emission tomography studies are usually done in only a few patients with low numbers in groups of about 20 to 50. And that's why, of course, you have differences in individual patients. Thank you. Other questions? If it's not the case, I will hand over to Dr. Oksanen from Finland.
Okay, good morning. This is not decent to be awake in this hour. So, I'm talking about treating opioid use disorder patients in Finland, and let's be clear, I'm talking about treating patients in southeast Finland, area where I'm working, because the practices are quite different in different parts of Finland. Introduction, disclosures, I don't have a slide, but I have fees from lecturing Indivio, Abwe, Gilead, Lilly, but no other systems. So I've been addiction doctor for 26 years now. I started in 1999, and I have been working in several cities all around Finland, half in psychiatric departments, half in addiction clinics. But from 2017, I've been in charge of opioid substitute therapy in the Kymenlaakso region in southern eastern Finland, which is from Helsinki about 130 kilometers to the east, next to the Russian border. And OST in Kymenlaakso region, my area, there are 3 major cities. They are within 50-kilometer range, each with its own clinic. And in Kotka I have 157 patients, in Kouvola I have 130, in Hamina I have 56 patients, and then we have health centers in the area where I have 25 patients, and those patients, every patient are monthly injection. Total number of patients was 343, total number with health center patients 378, and population is about 160,000. So that means there are over 230 patients per 100,000 habitat. And that's the highest number in Finland. So it's very easy to get treatment in my area. I'm the only doctor of those clinics. I have 18 nurses there working in different clinics, and a social worker in both clinics, all three clinics. Medication I use in clinic, I use Buprenorphine depot injection, Subutex monthly depot, and Buvidal. I use sublingual film, Suboxone, and methadone and levomethadone. Nowadays I have quit all the methadone. I use only levomethadone with those methadone patients. Depot injection in OST clinics are 75% of patients. If you count the health center patients, it's 85% of my area patients are depot injection patients. With Suboxone film, there are 18% of patients, and they are visiting daily basis. Levomethadone, I have 7% of all patients. A monthly injection of injection patients are 50%. All patients are 50% of all patients are in monthly injection, and weekly injection are 25% of all patients. And no home dosing with buprenorphine, and that's the historical reason is that buprenorphine is the most used intravenous drug in Finland, in opioids. Long-acting depot injection, I use Subutex monthly depot. It used to be in name Sublocade when I started. Monthly injection, both 300 and 100 milligrams. I started using those in November of 2020. Injection interval with Subutex depot is 28 to 35 days. I also use Buvidal monthly injection with all sizes. I've been using those from October 2019, and injection interval is 21 to 28 days, so 3 to 4 weeks. With Subutex, it's 4 to 5 weeks, sometimes 6. And I also use Buvidal weekly injections, also from October 2019. And injection interval with weekly injection in 5 to 7 days. The patients can choose which injection to use. I decide the dosage and the interval of injection. Patients can also choose to stay in weekly injection or stay on daily medication at the clinic with Suboxone or levomethadone. It's patients' choose, right to choose. I've been giving, we are using about 4,000 depot injections in a year, our clinics, so it's about 20,000 injections we have been giving since now. There are some clinical differences in monthly injection. The Subutex seems to be a little bit smoother, or patients are describing it smoother. It doesn't get so high in the start, and it's going slowly down. So it's a little bit long acting. People are free to switch injections. Some people are saying that we want to try the other one, and then they come back and things like that. There are switches in both directions, clearly more from Buvidal to Subutex monthly depot. And those patients who are switching from levomethadone to buprenorphine generally switch to Subutex monthly depot. It seems to be that Subutex is a better choice for those patients who are working or studying and want to keep distance to other patients under the clinic, so more close to normal life. And the advantages for the patients. The long-acting injection medication enables the freedom away from the clinic and the growth away from the user identity. That's the important thing. They grow out from that they are user identity. It supports working and studying and family life, of course, and stable plasma levels help to forget the addiction. enables the psychic recovery without constant changes of different substitutes. But also the chaotic type of patients, violent patients, psychotic patients, the life changes because otherwise we have to keep those patients endless in daily contact. But the stable plasma levels safely, the chaos reduces. We have very good experience from especially the heart patients. And for the clinic in Finland, it enables starting the opioid substitute therapy with a low threshold because there are no fear of misuse of substitute medication. And in Finland it's a big thing because, as I said, the most used intravenous opioid is buprenorphine. And it's, as I told you, it betters the treatment of dual diagnosed patients, especially psychotic patients with psychotic episodes, because we can give the depot injection both the substitute medication and the psychosis medication every 4 weeks. And the therapy point is very important because now we can focus on the therapy. We don't have to talk about medication in those sessions because they have the medication. It's very easy to execute, especially in sparsely populated areas, and for the stable patients in health centers, it's very easy. And just my clinical experience is that I have noticed that patients are returning back to the society. And the motivation of staff, the nurses, therapists, has returned because they don't have to fight about the medication, the home dosing and things like that. The cynicism has decreased because now we are seeing the change. I have a few cases. I have some time left. I'll just run through these. I have 4 cases, different kind of cases. First patient is female, 42 years old, has been before in OST 2019 until 2020, and we started second OST from July 2020. Borderline personality, very common in our patients. Of course, very traumatic background. I don't treat children of happy families. Very heavy drug use between 15 and 19, then she got pregnant, quit the drug use, but after divorcing 2007 started again. New spouse was very violent drug user. It ended the patient stabbed her spouse in self-defense situation in 2014. Did I jump? In that first episode, 2019-2020, patient was unhappy of the medication, film daily, and Buvidal injection in use of weekly and monthly. And when we measured the plasma levels with Buvidal, they were very high or very low. And that is when she withdrew from the treatment as planned. 3 months sober, after that she relapsed. Second treatment we started with Subutex monthly depot. Medication was okay, contact with the medication, plasma levels are stable. Now she's visiting clinic once a month. Life situation is stabilized, no need for intensive care. Second case, male patient, 46, paranoid schizophrenia, constant amphetamine use, daily basis, treatment history, psychiatric treatment history from 1995, continuous hospitalizations due to psychotic episodes. We tried Subutex film, didn't work because he was using amphetamine, didn't visit every day, didn't use antipsychotic medication either. We tried the weekly Buvidal, didn't change. We tried the monthly Buvidal, didn't change. We started Subutex monthly depot 300 milligram and Abilify Maintena in 2023, both received in the same day. And we continued with the 300 all the time. And now the situation is stable. Amphetamine use has decreased. That doesn't mean that he don't use amphetamine anymore. But he's not using it daily basis, not even in weekly basis. And most importantly, his commitment to the antipsychotic medication. He's visiting the nurse 4 times a month. Then case 3, female patient, 32 years old, bipolar disorder, borderline personality, starting OST 2018 with methadone. First year was really unstable because she was using amphetamine and opiates, was in hospital all the time. We increased the dose of methadone up to 140. We changed it to levomethadone in 2020 with 70 milligrams, which is same as the 140 methadone. She stopped the using of other drugs when she divorced her amphetamine using husband. The bipolar has been in balance since. But despite the high dose of methadone, still she was complaining of withdrawal symptoms, joint pain, swelling, cold, and felt mentally depressed and emotionally flat. We switched to Buprenorphine in May 2023 using microdosing method. We started Subutex monthly depot 300 milligrams twice, and since then 100 milligram every 4 weeks. So we switched it from levomethadone to Subutex. The physical symptoms with methadone disappeared. At first the mood swings intensified, stronger emotions, because she felt so flat before that. And she's telling that like she's awake after a long sleep. Case 4, no, I have to run. Age 48, male, of course traumatic childhood, start using drugs, alcohol, cannabis. Age of 13, amphetamine, main drug from 18 years old, started IV use then. Quite severe accident with car in 2008. He became addicted to opiates. He stopped amphetamine in 2016, and main drugs since have been Buprenorphine. Of course, numerous attempts of detoxification since then. I met him first time in 2018, August. He was not ready for treatment then, but a month later there was sepsis and very severe infection in spinal cord, and he has to learn to walk again. And he said that he realized that to recover he needed both God and OST. And he started in hospital 21 with methadone 40 milligrams, quite low dose. And since then no use of other drugs. And he became a member of the church, very active member. That was in his case very significant factor in the recovery. OST went well, but methadone caused constant fatigue and emotional flatness. And because the buprenorphine had been a primary drug, he was afraid of using it like medication. But when the injection therapy came, he changed his mind, no risk to abuse. We switched the methadone via microdosing to Subutex monthly, and we are dosing, well, we used to dose him 100 milligrams in 4 weeks, and every half year, one time, 300 milligrams, and that's based on plasma levels. I saw him now 7th of May, so a couple of weeks ago, and he was quitting the treatment. I gave the last injection, Subutex Depot, 300, no other medication needed of withdrawal, nothing. It's going to be follow-up for months. So over the past 7 years, no drugs, hepatitis C, we treated, got the driver's license back, which was the first motivation of treatment, married, and just got the first job. All is well. And the summary. The medication is only a tool in treatment, and for each patient, the best possible medication must be considered individually. But for my own patients, depot injections has proven to be the best solution for almost everyone, regardless of background, prognosis, or treatment goals. The injection treatment improves the quality of life and enables the patient to return to their normal life without the treatment defying the patient's whole life. And it changes the whole idea of OST. Instead of medication, the focus can be on therapy and psychosocial rehabilitation. Okay. Thank you for your attention. Any questions?
How do you manage cases when your patient continue to use non-opioid substance like alcohol, benzodiazepines, cocaine? Is it dangerous to continue him long-acting buprenorphine, or better to pass him to day-day sublingual form?
I don't. There's no difference in. Actually, there is difference in safety. The injection is more safe because you have the stable level of opioid in your body, and if you if you are giving the daily basis the buprenorphine or the home dosing, the patient can be injected. The home dosing, the levels are getting really high, and also when you are taking a daily basis, you are getting levels very high. Of course, we are dropping our patients back to the daily visiting if they are losing the control. If they are psychotic or if they are heavy using other drugs, we are taking them back to the daily basis, send them to the withdrawal, or we are just following a couple of weeks, and if it cools down, we are getting them back to the depot injection. But it's not a safety issue. I haven't had any patients lost with the depot injection now during these years. So no deaths
Thank you.
all. And we've been giving about 20,000 injections during this time.
Good morning. It's nice to be so early, so only the motivated people here. It's great. My name is Wiebke Dierks. I'm a medical doctor, general practitioner in northeastern Germany, close to the Baltic Sea. I work in a prison setting since 2015. The prison I offer like normal house doctor treatment, including drug dependence treatment. I also offer telemedicinic treatment for prisons all over Germany in a 24/7 setting, and if I'm not working, I have some leisure time activities. The prison I'm working in has 350 inmates, only male, normally under 5 years of sentence. The long time prisoners are in another prison not far away from us. The medical service is provided only on normal working hours. We have 4 paramedics in this time. After hours, there's just a possibility to call the normal doctor emergency system in Germany. No special doctors or medical personnel there. So we have to adjust our treatment in prison to this situation. I'm normally there 2 times a week for open counseling, seeing all the new inmates and discussing with them. They're already there, the further treatment going on, and having flu, having pain whatsoever. This. Normally from 350 inmates, we have like 10, maybe 20 right now on substitution therapy. That's due to in northeastern Germany, we still have this classical alcoholic problem without any other drugs, and now the younger people coming into prison and confronting us with drug abuses, but not this only heroin, but also polyvalent substances, everything they can get on. We use buprenorphine sublingual applications, polamidone, and now for, I think, 3-4 years, buprenorphine depot. Right now, these are old numbers, maybe 30 per inmates. I start with monthly depot on buprenorphine. I mainly was asked to present some cases, so I will go through them with you. You're really welcome to have questions about it, and it's going on, focus on the practical use of this formulation. So I have a 40-year-old inmate. He has a 20 years history of opioid abuse, also a 20 years history of getting in and out of prison. Right now he's the 3rd time with me in prison that I see him coming to us with oxycodone, 80 milligrams, 3 times daily, together with pregabalin and benzodiazepine. These medications were all prescribed by general practitioners outside. He was before on a substitution therapy with a specialist. There he dropped out because he had some arguments with the doctor, tried to strangle him, and that's why he's with us now. With this type of medication, he was very unstable, often dizzy, having withdrawal symptoms, not able to commit to working hours or taking in times at dinner, breakfast, whatsoever, in prison is offered, not going outside for the 3 rounds every day, and started also in prison to use synthetic cannabinoids that are the most available drugs in prison, as they come in on paper, filled with liquid, and they can smoke it. So I had many talks to him. We have been seeing us like at least 8-9 times to talk about the medication. Going down with the oxycodone, that has no indication on substitution in Germany, it's not allowed. The combination with benzodiazepine is not good for him. He was very insecure what should be done because he was always fearing a new withdrawal symptoms problem. But then at the end we get started on monthly depot. Then after, I think the 3rd injection, we really start to see him stable. No use of other substances, spice tests like the synthetic cannabinoids were negative. He could start working. He was working right now in a metal, I don't know what it's called in English, where you work with hot temperature and with a shield on. So it's very secure work. You have to be good on it, and now it's very good for him, working very well. And the other one, quite interesting case, 45 years old male, multi-substance abuse, that also led to his prison sentence. He, together with a friend, killed the 3rd person in the room, all under drugs, and then he tried to cut the head off with a butter knife, and things didn't go well. He had a lifetime sentence with us, spent now 6 years in the other prison for the long-time inmates. Then they normally come to us for social treatment with exposure to aggression therapy and stuff. And he had to wait quite long to get to us because he was always, again, in crime settings, aggressive, under drugs, and not following, not compliant. We received him from the other prison with alprazolam twice a day and sublingual buprenorphine. With his alprazolam, psychotherapy is not very good possible. If you're always under like a cloudy alprazolam feeling, it's not good to talk about your problems. So I said that we have to fade out and use the benzodiazepines, and then he said, okay, I will go with that, but I need the effect of coming down of the alprazolam. Then I said, okay, we can try to go from Subutex to polamidone. He was fine with that. Then was quite surprising that after like half a year, he was not using any other drugs anymore. He was out with alprazolam and no spice test positive, and come back to me and said, okay, now I'm ready, maybe we can try something that I can already start working here in prison and be more active. So we changed from polamidone to buprenorphine again. The reducing was subsequent to 20 milligram at the lowest, having 24 hours taking nothing, and then starting with buprenorphine. And after 1 week, we switched from oral medication to depot. And now the patient is actively taking part in therapy programs. He's really motivated and has a very good perspective to, in Germany, normally lifetime sentences is 15 years, the easy first point to get out of prison. Now we have, surely things will be happen after 15 years that he can get out. Starting with open, there was a possibility to go to the open ward, maybe, where you go out in the morning to work outside prison and come back in the evening next year. So overall, for the patient, this medication, they really like it because they don't have to go every morning to the medical ward in prison. As you can imagine, they don't come alone. There has always be someone to go with them, open doors and close doors. They cannot go with the all normal other inmates to work or breakfast. The pressure to give away of the substance is not there anymore. If you have an oral medication, there's always somebody to try to press you in giving it to you to use it as money in prison. And what they call me, they are less tired than on polamidone. And for the prison itself and for the medical team, it's far more easy to handle. As we are not there on weekends, if something's getting lost on weekends whatsoever, there's nothing to be lost on weekends. The contact of the inmates in medical department is not every day anymore, making it quite less busy in the mornings for us. We don't have to discuss dosing every day. Many inmates, if they are on oral prescription, they try to take less themselves and use the rest for others. And one thing that's really coming now more to importance for me is when I start patients on drug substitution in a prison, I have to be assured what's happening after prison. And in Germany, I often don't really know when they will leave. Normally the judge comes with an email, okay, he can go home, and that's next day. And if they don't have a health insurance, they cannot go just to the doctor and get your next prescription. And then this normally takes up to a week in Germany from prison health insurance to normal insurance, and this week is often too long for them. So if they're on depot formulation, I can start even if it's unsecure, because I now have this at least 4 weeks time to, for them to arrange their papers and go to a doctor again. Makes things very, very easy for us. No, I was very fast. Sorry. But maybe there are some questions you want to ask. Yeah. You maybe get the microphone.
Hi, good morning. I'm also an addiction doctor in a prison in Belgium, and I recognize this a little bit, but I personally struggle with convincing people for switching the Suboxone to an injectable depot, since there is a big market for the Suboxone in prison? They're selling it, they're earning their money with it, a lot of extortion. How do you try to convince them, or how do you try to do that?
That's a combination of talking about the good reasons and some pressure. I'm very frank with that. I say if there has any signs of treatment, we stop treatment. Any signs of trading, we stop treatment immediately. I don't really like it at all. Then I say, okay, you can get this buprenorphine, the substance I prefer normally to polamidone, only if you can go on injection afterwards. 1 week at least, and then we have to change, because the risk of treating is very, very high. Now we're taking this film you get in the buccal site. It's a little bit easier for us and more difficult for them to trade. But at the end, it comes up to getting depot or getting polamidone.
Yes, okay.
That's a discussion I have.
Great, thank you.
But then, I mean, I have to say, when they start on depot, like after 2-3 weeks, they are with me. They agree with that, because they see that social life gets much more easier in prison for them, because this trading hustle is not healthy. They see it. Anything else? Maybe for the other reference?
Yeah, maybe. This also. Maybe we just can open the discussion if there are questions on all three talks. Are there any questions?
Good morning. Thank you for your talks. I'm a physician from Israel, and I would like to hear how would you choose the Buvidal as opposed to the Sublocade, and because we don't have both, so I'm just interested in what are the differences.
So you were asking how to choose between Buvidal or Subutex depot. In my clinics, we let the patient make the choice. So usually patients have been on Buvidal weekly injection before going to the monthly injection. So they are used to trademark of Buvidal, and patients are pretty suspicious about the medication. They don't want to feel bad, so they usually choose. In early days, they usually chose the Buvidal, and the more and more there were people with Subutex depot. The good word about that medication spread, and more people wanted to try the Subutex depot. And there are still patients who are like the Buvidal more. They maybe want to visit more often in the clinic for other reasons, for psychological reasons. But those patients who want to work and want to be at as little to do with the clinic or anything of drug work, they usually choose the Subutex depot because it's longer acting, it's more stable. There are some downsides in Subutex depot. It hurts more when you inject it, and there have been some limitation of place where you can inject it. It used to be only in the stomach, and a lot of patients want to take it to the shoulder. And now we are using Subutex depot in shoulder also with 100 milligram dose, because it's smaller. The physical size of the injection is smaller, and there's no no problem with that. So I let the patients choose it. But it's a difficult situation if you have to choose one of those. That's the only injection what you can use. Because both of injection have their own good points. But if I had to choose one, I probably choose the Subutex depot for the clinic, because it has a little bit more advances. But I would insist that we can also use the weekly injection, because it's a very useful tool. If somebody is relapsing to the, let's say, other drugs, amphetamines, alcohol, then it's easy to drop. We step by step. So if month is too much, and we are losing the patient, we don't lose him on the side. So we can drop him to the weekly, or she to the weekly injection. And if that doesn't work, we can drop her or him to the daily basis, and then lift up back when things are okay. So as I said, they are only tools. You have to choose the right tools. Okay?
Okay, and I would like to add, I think it's just a question of dosage. So if what I have shown is that Subutex depot produces a high plasma level, and therefore I personally give patients Subutex depot if they think they need a high concentration, and if they need a lower concentration, I rather would give Buvidal, which is also available in different concentrations. And therefore, sometimes when patients already say, I only have a short time of opioid misuse and I want to go out, then I would prefer Buvidal, because then I can go down with the dosage. And other way around, if I have someone who is constantly on maybe 16 milligrams of sublingual buprenorphine and also takes alcohol, benzodiazepines, or other drugs, I would choose Subutex depot to put him high and to enable him to stop this use of non-opioid drugs. Are there any? Over there.
So hello, thank you for your excellent presentations. I'm Hanna Särkilä from Finland also, and I was just wondering, perhaps Juha can answer, have patients said some reasons why they will stay on sublingual buprenorphine or methadone and don't want to change to injections?
Yeah, sure. There are many reasons I can really understand to stay on daily doses, because they need this healthcare contact every day. It's time of social life, of daily structure to go to the medication. Also this learned effect of getting something every day and feeling better after taking it. And that's really something you have to discuss with the patient if he wants to. And then there are many, many other reasons I don't really like prison settings, but this I can understand, and that's mainly the most reason, because at the end it's this buprenorphine making you less tired, making you more active to the day, but some people want to be tired and want to have the day in clouds, and I can understand that, and that you have to discuss with them.
Yeah. For the same question, some patients feel more safe if they have the reason to come to the clinic every day for a while. Some patients have principles. I have one women patient which I changed the buprenorphine to the methadone 4 years ago because of selling of buprenorphine. And now I'm ready to switch it back to the depot injection, but she said that when I once made her use the methadone, she's going to use it end of the days. That's the principle. And some patients feel that they, as I thought, they want to come every day to the clinic. It's the social thing, it's the safety thing for them. But occasionally they have to go to some other city, maybe visiting relatives or going on vacation. They can take for that time injection, and they are free to come back to the sublingual if they want. And most of the times when they try just visiting another city, they notice that it's better than the daily, so they are keeping that. But they're suspicious. Okay.
Sorry, thank you for the opportunity. I've seen the advantages of buprenorphine as presented, but what about the disadvantages also? Have you looked at it vis-a-vis the use of methadone? I know several years back, 15 years ago, I did a study in UK. The main reason why we give methadone was because we are able to check the injection site of the patients when they come in to take their medication. They are being monitored for any other behavior, and then we know when they need help. So in terms of, I know both has both advantage and disadvantages, but what about the disadvantages of buprenorphine on the patient side? Thank you.
When I got you right, there's a problem with injecting, because then when you inject these depot formulations, of course you use the same way, and you still have you can see the injection sites, and you're not sure whether patients are injecting drugs, or was that the question?
So, like we know that the use of the opioid agonist is part of the broader spectrum to reduce harm. And we know that majority of our patients that come in to take their medications are also injecting drug users. So we use the advantage of dispensing, sometimes to check maybe their injection sites, if they need more help, if they are more stable, and then kind of public health advantage, kind of, because we are able to also monitor them to see if they have erratic behavior or they've started to withdraw or to go back again to the use of the substances. Another challenge we've noticed is also that because methadone itself is a synthetic analog of what they are taking, sometimes they tend to be on the medication for a very long time. I've seen pharmacists dispensing methadone for over 40 years for individuals that they've refused to taper off. So these are the advantages and the disadvantages of the methadone. So I just wanted to know more if there are also disadvantages for the use of buprenorphine. Thank you.
The problem that many clients tell me in the beginning is there's this nice effect of methadone, feeling the drug fluting on and feeling better with taking it, they're really missing when they're on buprenorphine. And when you have somebody who really needs high doses of methadone, like 160, 200 milligrams, and buprenorphine is just a partial agonist on the receptor, they don't feel satisfied. That's sometimes. It's not often, but they say it, and then you have to believe them. And then they go back on methadone, and then they're fine. But just the ones with a very high dosage.
Sorry, I have two more questions a bit linked to that. I think you had a case report as well about someone with a bipolar disorder or a borderline personality disorder. When we talk to the treating psychiatrist of one of the patients, they often see that as a reason to not switch them from methadone, especially higher doses, since they're afraid of the clearness in the head that the buprenorphine gives.
Yeah.
What's your experience with that?
Yeah, it's. I've noticed that I have several female patients who have been describing, and some male patients also, describing that it's overwhelming, the emotions is coming back. But it doesn't affect the bipolar disease. It doesn't get any maniac episodes or any depressed episodes. They are just feeling stronger, the feelings, and they have kind of forget that during those years with methadone. So they're a little bit, shocked like that. Oh God, I'm crying. How does my feelings is coming so strongly? But they get used to it. And of course, sometimes you have to put the medication a little bit higher. If you have a lithium or some antipsychotic medication, you get a little bit getting for a short while a little bit higher and then getting down. And there's no problem. I haven't had case where I have to switch back to the methadone because of that kind of problem. That the mental diseases, mental illness is getting worse because of buprenorphine. But of course, the methadone is stronger medication. As you said, they are sometimes, missing that feeling of methadone, that dumbness, and that, how can I explain? But you understand what I mean. You have to live a little bit more clear life if you have buprenorphine, and that's hard for somebody. Thanks.
I would like to add, I'm a psychiatrist, and I think it is an alternative for giving methadone is giving buprenorphine instead, combining with other medications that are just making you tired a little bit or sedative. So there are quetiapine, promethazine, there are a lot of low efficacy neuroleptics that you can use. And this is something just to negotiate with the patient, I think. But I think it's good to have in mind that you're not stuck to only methadone produces some sedation. There are alternatives, and that's what you can use when you discuss with the patient. And you can try it before, maybe. You can just prescribe like quetiapine or promethazine and ask the patient, is it better now, and would you like to try then? Because then you have more possibility to, for daily life, you can adapt it. And one day give more quetiapine or promethazine and another day less, and when you're constantly on buprenorphine. And so you have these possibilities.
Okay, thank you. And then maybe one last question about the dosing, because in Belgium I can only use Buvidal. And in my experience, I often see that the first monthly doses are typically a bit shorter, or the patient is comfortable for a shorter while. And I think they say that about after 4 monthly doses it should be stable or something, but I know there's a big difference in some patients being stable really fast and other ones not getting there. Is it sometimes then also time to just up the dose, despite them saying, hey, the first 3 weeks I'm great, I feel perfectly fine, but then I crash? Or is it just okay to just keep giving it every 3 weeks in these cases, or should you up the dose?
Well, my short answer is in Buvidal it's often the case that after 3 weeks in the first injection or in the first 2 injections, after 3 weeks withdrawal symptoms appear, and from the 3rd injection or from the 4th on the problem disappears, because then in Buvidal it's not, the plasma level is not 0 after 3 or 4 weeks, but there is still something. And though you come up with each injection a little bit higher, and you need like 2 or 3 or 4 injections to be high enough to have the full effect for the 4 weeks. But maybe we can pass over to those also with a lot of clinical experience.
Yeah, I mean, when I started with Dipol, I was a little bit too concerned about the dosage. I was going too low in dosage. And now as I realized for myself that I cannot kill him with an overdose because they're still breathing. And on the other hand, they cannot trade it, so there's no reason for them to get more just for trading them. I get up with doses to get to the patient's needs and what he asked for, and now everybody is satisfied, just going higher in dosage. And these going from milligram daily to milligram weekly, monthly calculation formula is quite low and just going up, and everything's fine.
Yeah, I'm measuring plasma levels quite often for patients who are complaining withdrawal symptoms just before the next injection. And if it's low, it's usually the Buvidal, so I take a little bit shorter while. And if it's the Subutex, I just give another 300 to getting high, and then after that 100. But when I start Subutex Depot, I'm a little bit unorthodox. I don't give any sublingual medication with that. But if there are clearly withdrawal symptoms after 2 weeks, I could give, like 8 milligram weekly Buvidal for rest couple of weeks, and the next Subutex Depot is going to be all right for the whole time. So you can try different kind of things in clinics, to make things go right.
Thank you.
Okay. I think if there are no more questions, I'd just like to thank for your attention, and I wish you a further very good Congress here. Thanks a lot.